to end your life.
Good evening, everyone, and welcome to the fourth Conversation That Matters series. My name is Caroline O'Regan. I work with the Institute of Leadership in the Royal College of Surgeons in Ireland. I am very pleased to have this opportunity to continue our discussion about ethics in the COVID-19 crisis, specifically loss and bereavement. This is a complex and sensitive area and is particularly challenging in this pandemic. I want to welcome back our panel of experts, specifically Dr. Miriam Colleran, who is a consultant in palliative medicine with St. Bridget's Hospice and Naas General Hospital. I would also like to welcome Ms. Nuala Harmy. Nuala is Family Support Services with St. Bridget's Hospice. And I would like to welcome back Dr. John Fitzsimons. John is a consultant paediatrician with Temple Street Hospital and also a clinical director for quality improvement. And finally, I would like to welcome Dr. Coleman O'Loughlin. Coleman is Director of Critical Care with the Mater Hospital in Dublin. They're all joining us this evening to continue our conversation about ethics in a more specific sense. Last Thursday, we talked about ethics and some of the learnings from the specific situations surrounding decision-making for critical care. We also discussed the Department of Health, WHO, and other guidelines that have been developed in Ireland to support healthcare staff in this pandemic. This evening, we want to continue the conversation, specifically about issues of isolation in caring for COVID-19 in ICU, and also the impact on families feeling isolated, not being able to visit their families in this pandemic. Miriam, Nuala, Coleman and John, it's lovely to see you this evening. So I'll pass you over now to Miriam. Welcome back, Miriam, and joining us in continuing this conversation on ethics.
Thanks very much, Caroline. Last week, we discussed assessing patients clinically to help establish the individual patient's performance status and its relationship to escalation of care and the personalised ceiling of care. I want to extend many thanks to Dr. Emer Hearn from CUH and Dr. John Bates from UHG, who kindly spoke with us last week. Psychosocial care is an important part of medical practice. COVID-19 is having an enormous impact on psychological well-being and on our society, both directly and indirectly. Patients are self-isolating at home or in hubs. Some infected patients are ill at home or in hospital or in HDUs or ICU. Some are isolating in nursing homes and residential care units, and many others, sadly, will die. Their lives sadly shortened by COVID-19. As a nation, we have engaged in social distancing, as we all know, and we are now in lockdown and will be until May the 5th, and after that, the future is still unclear. Traditionally, we are known for being a very welcoming people, and particularly in recent years, we have become quite demonstrative. But now, suddenly, we cannot shake hands, and while household hugs are allowed for children, for the most of us, hugs are not allowed. We had a strong culture of supportive funerals here in Ireland, an envelopment of the grieving family, and we valued supporting and being there practically for the dying patient, but also emotionally, spiritually, and addressing existential concerns was also very important to us. Life in this pandemic has seen a rapidly changing landscape, particularly around funerals, and now we have a very different funeral practice during COVID-19. Anecdotally, we are hearing stories internationally of loved ones being unable to see their dying mothers, fathers, siblings, family. Huge stories of emotional loss and being physically apart at a time of need for closeness and support. So today we would like to discuss this and see what we could do to help. And recognizing that this is a very much a changing progressive situation, that what we're discussing today may change another time, and that many services are starting to address individually how we can support families in seeing their dying loved ones. This reminds me of Viktor Frankl in Man's Search for Meaning saying, "When we are no longer able to change a situation, we are challenged to change ourselves." Everything can be taken away from a man but one thing, the last of the human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way. Between stimulus and response, there is a space. In that space is our power to choose our response. In our response lies our growth and our freedom. And COVID-19 pandemic also reminds me of Dr. Ira Byock in his recent article, A Crash Course in Being Mortal, where he talked about our different tasks at this time. Assignment 1, stay safe. Acceptance of death is oversold. Dylan Thomas had it right. Why not rage against the dying of the light? After all, we're going to be dead a long time. An effective strategy for the living fully. An effective strategy for living fully is to not die prematurely. So we are hearing from these great physicians and medical educators about the importance of self-care at this time, but also about person-centered care. Tina will kindly upload links to references into the live chat that may hopefully be of interest, including practical documents regarding funerals at this time, advice on communication, in particular from the Irish Hospice Foundation, relaxation techniques for patients, and a podcast on therapeutic presence. I am very fortunate to be able to say that Nuala and I have been working together for 8 years or more now in St. Bridget's Hospice, and we have done many family meetings together. Nuala, I know this is an area that you specialise in, and I'm delighted to have you here today and to get to chat. Firstly, I was hoping that we might chat about the sudden change in the way we are having funerals.
Thank you, Miriam. I suppose, all experiences of death and dying occur within a particular social framework. Rituals do change and evolve, but by their nature, they change and evolve very slowly. What has happened in the past month is that the ritual around death and funerals has completely changed overnight. And obviously, this is going to have a huge impact on how people grieve.
Sure.
I suppose Philip Ares, who's probably the most influential historian on Western attitudes to death, said that funerals really are a sense of continuity between the living and the dead. And this is expressed almost visibly in the way the living and the dead literally rub shoulders in a graveyard. Death is one of the major focuses of ritual. And as I say, this has abruptly changed overnight. Rituals are important, very important for grieving people. They move the individual who has died to a different form of existence, but they also reassert the continuing life of the remaining family. Rituals provide stability in a world that is shaken by death.
Okay.
And the types of death that we are seeing now, both of COVID patients and indeed of non-COVID patients,
Absolutely.
are, people are not able to be with the person who's dying,
Sure.
not able to be with them in the fullest sense that they were before. So these people more than ever need to have the stability of a well-established routine, because grieving people are following a prescribed and taken for granted pattern that they understand to be correct, respectful, and a good response to the fact of a person's death.
Okay.
And this pattern is really, you know, it's very rich with meaning. It talks implicitly about the communication between an individual and the community, between an individual and the family. And as I say, that ritual has been removed overnight.
Okay.
It's too soon yet, actually, Miriam,
Okay.
to draw any conclusions from the abrupt changes in funeral practices. Anecdotally, from my own practice, we're too near the event. We're talking about funerals that have taken place in the last month. But it is quite clear, even at this stage, that people are very distressed about what they perceive as not proper funerals, not being able to say goodbye properly. The absence of a ritual and the sense of isolation is enormous. And I mean, all you can say is that this is going to impact on grieving down the road. And it's something that we need to be very much prepared for. I think we have to offer something to families. Obviously, this is something for faith communities.
Yes.
It is something, the leaflets you've talked about are extremely good and helpful. They need to be given to families.
Okay. Can you explain that a little bit more to me when you say, Nuala, they need to be given to families?
Because grieving people are in a state of confusion and they will not know where to go to look for these.
Okay. Because they are freely available online. But what you're saying is that we as clinicians need to literally be proactive about it.
Exactly. Perhaps have them. I know one acute hospital where they are actually available and are given to families at the time of the death. In another hospital, the chaplains are actually phoning people, say about a week after a death, just to check in with them, just to try to hold them.
Okay, all right.
You know, and I think we are going to see down the road a lot of people who are distressed and upset and haven't any sense of moving on to the next stage of their journey.
Okay. So you've been, I'm hearing you there very much, Nuala, talking about us being a therapeutic presence for our patients as they're dying, but for our bereaved families in their acute grief. What about children?
Well, I suppose, you know, COVID is not a pediatric disease, thankfully, but, you know, children are very involved in this. And for those of us who have worked for years with children around the whole area of bereavement, again, everything has been turned upside down. For children to understand and process what's going on, they need to be involved in as much as they want to be. They need to have information. They need to have explanations. And in this present climate, where things are moving so fast, they actually are excluded from what's happening. They're possibly not getting explanations. And again, I would refer to the Irish Children's Bereavement Network have done excellent work with advice for parents. But if families are bereaved and there are children involved, whether it's a grandparent who's died or a parent, whoever is significant to the child, that these leaflets are freely available. Because people who are bereaved, particularly people who are trying to cope with their own grief and a child's grief, they're not going to sit down and go online. They need to be handed something.
And we might actually come back to this again, Nuala, if that's okay, because John and Coleman are going to chat now. Thank you very much.
Thank you.
Thank you, Miriam. Thank you, Nuala. I'm going to pass you over now to Dr. John Fitzsimons and his colleague Dr. Coleman O'Loughlin to talk about isolated incidents, isolation in relation to ICU. So thank you so much for that. That was terribly informative. Thank you. John.
Thank you, Nuala, and thank you, Miriam. Yeah, I think there's no doubt that one of the impacts that we're seeing, I think, as clinicians is in terms of our loss is through this this enforced isolation that this illness is bringing upon our work lives and our home lives, and I think some of the normality, that we have for working normally, and the human contact, both physically but also in the nuance of communication, and I think that isolation also I think causes us great fear about the future. And I think one of the nice pieces I came across in the last couple of weeks was from David Kessler, who's written a lot about grief, and he was talking about this idea of anticipatory grief, and this was particularly around the feelings that we have of uncertainty for the future. And I guess they're all compounded by the fact that it's hard for us to get together to talk to others about them. But he also, I suppose, made some proposals for things that might help. And the first one I think he identified was this idea of acceptance. To look for the things that we can control. We can wash our hands, we can keep a safe distance, we can accept the situation as it is and start to deal with it. And the other suggestion he made was to stock up on compassion, which was a phrase I liked. And I think it brings us back nicely, I suppose, to this idea of ethics, that compassion is about, I suppose, actions directed by the fact that we care. And so I suppose it's my pleasure this evening to get to talk with my classmate and my old friend, Dr. Coleman O'Loughlin, who is the Director of Critical Care at the Mater. And I know Coleman and his colleagues have been, they've accepted, the challenge that's in front of them, but they've also, I think, started to act compassionately in terms of trying to deal with this new situation in a way that is person-centered. And Coleman, it's a pleasure to have you here this evening.
Thank you, John.
Coleman, you might just talk to me. Why is COVID different in how it's impacting how we care, and what's it doing to how we care for people in hospital at the moment?
Yeah. Again, just to borrow one of the phrases that's being used a lot recently, is the frequency of the word unprecedented is in itself unprecedented. We've never seen anything like this before. And I think was mentioned by Nuala early on, this came on very, very quickly. We had some warning, but the rapidity of this is just extraordinary. We have, and I'm speaking from an intensive care practice, which is very kind of, it's a very specific practice within a hospital, but it itself has been very static for many years, small developments here and there, etc. But the core of our work has been, I suppose you'd say, static, very stable for a long time. And that's around, the word I'd focus on is intensive, as part of intensive care. It means a lot of staff working in a very small area, a lot of very sick patients who are critically unwell, a lot of interventions such as intubations, tracheostomies, lines, all those things, and it's a very intensive area. And part of that is because the patient is so sick, we have to build up a very trusting relationship with families and the patient themselves, those of them who manage to stay awake through this. A lot of them are sedated in a coma, but there's many of them who are asleep in a coma, and our focus then is to deal with families, and we work very hard to build up a trusting relationship with families. We try and put a face to the name. They try and put our faces to the name, and over the length of stay of a patient in ICU, which can be for 5 days to many days and weeks, we develop a relationship. And I suppose that's the biggest change that we've seen. We don't have that family interaction anymore. That is gone in the traditional sense. we forget too that one of the cornerstones of society, and Nuala mentioned this, is the funeral process. But bring it back a few steps, and one of the cornerstones of society is our unspoken moral obligation to, I suppose, to support sick people, to show solidarity with those who are unwell in society, and that's the simple. And it sounds a little bit idiosyncratic, but bringing the bunch of grapes in the old days to the hospital, you're just going visiting people in hospital who are unwell. You don't know why you're doing it a lot of the time, but it's part of our society, it's part of our culture to that. And again, as we mentioned, it's gone pretty much overnight. People aren't allowed to visit their relatives overnight. That's a huge impact on the families, a huge impact on the way we practice. So apart from the stuff you see on TV, which is all your PPEs, the lack thereof, or how much that's around, the working conditions are very difficult for the nurses and for ourselves. The apprehension that exists among staff, which we can talk about as well. But I suppose one of the most fundamental differences is that complete lack of visitors into the intensive care area, which was so stable for many, many years. And it is very difficult for people to come up with solutions to that. But we do try. We do try.
And obviously those are things that are impacting on the experience not only of patients but of families for this critical time. And I heard you talk the other day about, even when people are offered, to come in and put PPE on, that they find that difficult. Why do you think that is? Or
well, there's a lot going on. I mean, we forget sometimes that when a person comes into hospital, they're critically unwell, they go to intensive care. They're usually, not always, but usually part of a wider family, and that family are often considered close contacts, and by definition they're not allowed into the hospital. So they're isolated on many fronts. So they have a very sick relative in the intensive care who they can't go and visit. Their normal support circles, who would be their siblings, their sons and daughters, their own parents, whoever, can't come and visit them because they're socially isolated. So on both fronts, they're very, very challenged. So when we do see somebody who is in a I suppose, coming towards, maybe not quite as far, but maybe coming towards an end of life situation in the intensive care, of course we make every effort to try and get whatever family members can come in. And I can recall one patient that the only immediate family member that could come in was a sister. And we made a lot of effort to get that patient from up the country. She came in. She was very, very apprehensive about the PPE. There's an association, I suppose, of PPE and the fear of not getting that right, the fear of not putting on the PPE correctly, that it increases their chances of maybe contracting the illness. It's very difficult to deal with that when meeting a family member the first time in a short time frame. But PPE works very well, and we do very good kind of practical informed instructions how to put that on. But they still see it as something that if they don't get right, they're at risk, and that's understandable. But this particular lady came in, and it was her brother that was very, very unwell, and she stood almost exactly 2 meters back from him, and she sang, and slightly humanistic in its way, but it was extraordinarily moving, and it was just something they had between themselves for many, many years, and it touched the staff a lot too, because it was totally surprising. That was how she approached this end of life situation for her and for her brother in that unique situation. But it was so, I suppose, it was such a relief for the staff that they got that opportunity to allow this to happen. But to go back to your question, yes, families are apprehensive about coming into hospital. There's signs everywhere. Don't come in here. You're not welcome. They're not written to say that, but yeah. It's the public message we're trying to give, obviously. So when we're asking to come in that environment, they're very apprehensive, and we get that. We try and support them. It's all communication, talking.
And obviously, I suppose the other big group that's influenced or impacted by isolation are the staff, and even been open to these ways of new ways, perhaps, of seeing people interact with their relatives or facilitating that and helping them. And I'm sure you've seen probably great examples of people adapting to the new demands of COVID practice.
Yeah, as I said, this came on so suddenly, But in some ways, we've always had highly infectious diseases in the community, and usually in the form of influenza. And that comes around seasonally, occasionally as a kind of a pandemic, as in 2009, the H1N1. So we've always had patients that we've had to have isolation, we've had to have the PPE on and stuff. But it was one patient, and it was manageable within a broader group of healthcare workers. It's entirely changed now when all your patients are isolated, and therefore the healthcare workers attached to that patient by definition are isolated too, for many reasons. But one is obviously the risk of transmission of disease if we don't have strict protocols about entry into the room and exit out of the room. There's also the secondary issue of not having to change out of PPE too often and trying to conserve stock of what is now valuable PPE. So every time you go in and out, you have to change. So, but that creates a sense of isolation for the staff that are in there. And again, we had no idea how that would play out. The first couple of days of this we didn't really know how it would play. But what we've seen is extraordinary resolve from the staff. Simple things like when you look into a room, all our rooms have glass fronts. It's impossible to tell who the nurse is because they're head to toe in PPE. All you can see is their eyes. And you might, every room has a phone, you ring in, and you felt very embarrassed for saying, who is that? So small things, they've got a little sticker to put it on the door. The nurse today is Mary, Pat, whoever it is. And small things like that, and they get a sense of kind of reward from actually people knowing who they are. Small things make a big difference in these situations. But what we also seen is we would normally have a double team, so a nurse would look after a patient. When they go and break, the nurse next door would look after their patient, and vice versa. Now that has been branched into bigger teams, because the bigger the group that can do that type of behavior, the more support there is within the day. And in some ways, I have seen situations where the mood from what was very tinged with apprehension, anxiety, fear, the first few days at least, if not the first week or two, because this was brand new. This is the first time healthcare workers were coming to work, and there was a genuine risk to their health, a possible risk to the health of their family. None of this was something that they had considered long term, but it's moved almost, not say quite, to the opposite side, but certainly the kind of esprit de corps. The atmosphere has improved dramatically, because they've adapted along the way by, as I said, one of these things, putting a name up there, forming teams, trying to debrief as the day goes by rather than end of day debrief, through jokes, through stories, through whatever. It's quite a different environment, but a very enjoyable environment to be in at the moment for bizarre reasons.
And organic in one sense, I imagine that's probably something that's just emerged, and people weren't told to start kind of telling stories. It's how people are responding, and
yeah, exactly.
I see my colleagues in Crumlin got a consignment of walkie-talkies, I think, from Smith's toy store to help them communicate with each other.
Yeah, and subsequently they ended the whole supply of walkie-talkies to Smiths in Ireland, because it's a fantastic idea. It wasn't necessarily relevant to us. We have a 36-bed unit, and that many walkie-talkies just to cross-chat would be incredible. We have phones in and out, but it's certainly for a lot of units. It was a very, very innovative solution to problems of communications. And but as I say, it's organic. We had planned, and I mean, people will be, I suppose, somewhat aware of this idea of mass casualty incidents. And since September 2001, and terrorist bombs along the way, and natural disasters and plane crashes and whatever, each hospital in Ireland has a mass casualty incident surge plan. So we had a surge plan built in terms of how many sick patients we might need. We'd escalate to surge 2, surge 3 if we had this many patients, etc. And we had a plan for that. But it was in terms of inorganic stuff like rooms, ventilators, space, if you like. We never thought of staff. We thought of staff, but again in numbers rather than actual staff sentiment and staff welfare. But this is different because this brings with it the isolation element of it, the social distancing element of it, which is extremely hard to achieve in an intensive environment. So it is such a challenge, but it is extraordinary to see how it develops over time, and how we come up with solutions to help staff, how the staff come up with solutions to to help families and patients who have come through this, and I'm glad to say that we haven't arrived at a situation where we've required a funeral too often. Most of our patients have got better, are still with us, which is really good news. But those who have got better, I've never seen them so active on social media, on their phones, because they're catching up for all the time that they were in isolation. And now even social media in isolation is not isolation anymore, because they have an ability to react to the world outside, which they didn't have when they were intubated in a coma, and they've come through a horrendous experience. So watching all this evolve all around you just gives you a totally different perspective of what we've been doing since 1952. As it happens, a lot of people won't know, ICU developed out of a pandemic in Copenhagen. Polio, it wasn't a pandemic, it was an epidemic. A local epidemic in Copenhagen, where a load of non-medical staff, students, nurses, and lots of people were asked to bag patients who were paralysed from polio in a room together, and that was the first intensive care. So there's a symmetry there. But to see the evolution of how things pan out in a situation where it was totally unpredicted is a joy to see in many ways.
Yeah, and who knows what new practices and new ideas will come out of this pandemic, and what changes. Well, thank you, Coleman. I'm going to hand over to Tina, and we'll see if we have some questions maybe for yourself and Nuala.
Okay, thank you very much, John, and thank you to all the presenters this evening. There aren't any questions, but there are two very nice commentaries in from Helen and from Angela, and it just brings up that theme that both sort of speakers talked about this evening in terms of rituals. And Helen very nicely describes how her father died, and the walk to the graveyard and the community coming out to line the streets along, and that gave them a lot of comfort in doing that. And Angela also brought out the same point. Angela is doing contact tracing, so she's engaging with families who have been bereaved. And she's just talking about the impact of the loss of ritual, the cups of tea and the biscuits, and being able to talk about somebody's life with people and over a cup of tea, and that's having an impact on staff as well. And that's just kind of echoing what Coleman was talking about there, that this impacts on staff in lots of different ways. So they're just two of the really nice comments that are there this evening. So back over to yourselves.
But there's one aspect we actually haven't covered yet. There's an aspect we haven't covered yet, and Nuala, I might explore it a little. Coleman has and John have obviously discussed it from an ICU perspective, but I suppose, Nuala, I was thinking really more in terms of patients, families who themselves are isolating at home, so they may not be able to visit, or for many of our patients are in hospices, and many of patients, or we have a lot of patients who don't have COVID but are still subject to visiting restrictions, because that's what we're doing nationally to help prevent spread of COVID. So I suppose, Nuala, would you speak to that in terms of the impact of isolation and social distancing, which is necessary at the moment, but the impact that it's having on loss?
I think what I've been seeing very clearly over the last few weeks are people who are cocooning because of their age,
sure,
who are bereaved, who have a sort of a funeral, as they describe it, and then are moving back into their own homes and are cocooned there and are on their own. You know, and there's a huge sense of missing the kind of, and generally people of that age, they will use the phone, of course they will, but they're not as good on social media as maybe younger people are.
Sure.
So there's a big sense of isolation there too. But I think for people who have relatives who are in hospital or in hospice, who are having to isolate, there's a level of anxiety. It's actual anxiety about what is happening to the relative, how is the relative, how are they awake or are they asleep? Are they missing them? Are they, and you get this a lot with people who have relatives in nursing homes.
Sure.
People maybe have dementia, and the distress of the relatives is, will they understand why I'm not there?
Yes.
Are they fretting because I'm not there? And again,
Sure.
it's down to communication. You can't do anything about that. That's the way life is for all of us at the moment.
Yes.
But, in some places, they have specifically put people there who will communicate with the relatives, who will actually ring them and talk to them and say, so-and-so is okay, and I have tried to explain to them. It's all about communication.
Sure.
It's about communicating with people, because for any of us, particularly after a death, the way people will go through, did they say something when I wasn't there? Did they? Yeah. It's all of that. I was talking to a chaplain today in one of the acute hospitals who rang a family, and the daughter had come from England. She hadn't seen her mother before she died. She arrived too late, and she wondered, did her mum say anything to the priest who was called in? So the chaplain rang the priest, who was a parochial priest, and he rang the daughter.
Okay.
And even that kind of communication,
Really important.
that he could say, your mom didn't say anything, but I was there when she died. It's
really important.
Well, it's very important for anyone when
Yes.
someone dies that you have knowledge of what happened.
Yeah, and as a family member, to know that they weren't on their own, that there was someone with them. As a society, it's coming back to what Coleman's saying about that undercurrent and belief in our society that we need to be there for our sick. We want to be there for them. We want to support people. It's something that we believe very strongly as a culture and as a people in. And I think that's very much linking what you're saying there, Nuala, that it was so important for that daughter to know that her mom had someone with her.
Yeah. So it's around communicating, if the family can't be there, for someone to communicate with them around how the actual process was for their person.
Okay, yes.
That is part of it, because if you're working with bereaved people in the early days and months after a death, they will continually go over what happened when the person was dying. It's part of the moving on process, and then they leave it. But if you don't know what happened, you then start to imagine.
Yes.
And imagining is usually worse than the reality.
Okay.
So
Okay.
Thank you.
Can I just point out that a lovely resource I came across this week from Eva Doherty in the RCSI, and I think we'll try and post it as well. It's a short video Eva has made around responding to patients' distress and strong emotions, and I think a lot of the things we're talking about now do evoke strong emotions, and I think it's very important, I think, as healthcare professionals, that we are able to deal with this and I think not necessarily get drawn in. And it's a very nice, very practical short video. It's only about 6 minutes, so I think we'll try and find a link to that. But I think it fits in very nicely with what we've been talking about. I think that the stress that comes with, grief and bereavement and loss and separation from people and normality. So I think that's a helpful resource, and I think that they plan to have some more of those, I think, available soon.
Yeah, and we're finding, if I can come in here, there are solutions. They're not the most ideal solutions, but there are solutions of a sort to some of the problems we're seeing. We know for a long time that if you're unwell in hospital, but you're not critically unwell, that you can pick up a phone and you can answer a phone call, and that substitutes for people needing to be there. But in the kind of end of life process, the patient doesn't have the ability to verbalize, and therefore the demand on the family or next of kin to be there becomes even stronger, to see the patient. If you hear from them, that's almost a good substitute. But if you can't do that, and that's where modern technology has really helped us. And I would have always thought that things like FaceTime, video conferencing, whatever name you put on it, was a very poor substitute to being there face to face, but only reasonably about how good a substitute it actually is when the chips have fallen and you need something. It was not that long ago we didn't have that. And we have certainly used that. There's possibly GDPR issues, but most of us have thrown that out the window. We don't really care. This is more important.
Yes.
And there's ways, and I know that one of our colleagues, a surgeon as it happens at work, is very into tech, and he's trying to develop a solution where we can do FaceTime type video conferencing with a family member and a patient who's obviously in a coma in ICU, but still, we can log it into hospital systems, an event that's happened, and make it formal but yet accessible for the family. So there are solutions. And even, as I say, it's good to see in today's or yesterday's New England Journal of Medicine out of Boston, there's a report from, I think, a hospital in Detroit. If I just bring it up here, it's Not Dying Alone is written down. It's a perspective piece in the New England Journal. And it's written as if it was written in a Dublin hospital, Limerick Hospital, Galway Hospital, and the solutions are exactly what we're trying to achieve here in Dublin. So it's a global problem. Sometimes it's reassuring to hear that or to see that as well, that we're not in this alone.
Thank you.
And I suppose
Yes.
just in linking what you were saying there, Coleman, actually, I can't remember the wording off, but in GDPR, there's actually a special caveat in it actually about the overriding public interest and particularly in public health concerns, so there is actually a built-in caveat about that, about acting in best interests.
Okay, thank you so much to our panel. Huge appreciation and gratitude for this evening's conversation. And I can't believe we've run out of time already. Just to finalise, I suppose, to try and summarise our discussion, rituals are terribly important in Ireland, and this has changed overnight. That clinicians, we need to be proactive about the materials that are available for families and to look at the whole area of anticipatory grief. That family isolation is crucial, and the whole discussion around PPE, the possibility of catching the illness for the families, and indeed the apprehensiveness of family members coming into hospital, but also then the whole thing around isolation of the staff. And that beautiful example that was given about staff who write their names outside of the ward. So apart from that helping with the sense of belonging and teamwork, it also motivates the staff that you know who they are. And that this is very organic in this change in way we practice what we do, and that people are adapting as quickly as they can. And the whole thing about the double teaming, and I really thought that was crucially important around how that teams check in with each other, and everything that we do and read refers to that as really important for communication going forward. And then I suppose that social media in isolation is not isolating anymore. And I mean, that became quite a living thing when we talked about the type of solutions that we're using now to help support families, and how that modern technology is really helping supporting that. And I suppose I want to finish by saying that the patients whose lives are sadly cut short by COVID-19, we want them all to be peaceful naturally and die appropriately. And that we're hoping to continue this conversation next Thursday, the 23rd of April at 6:30 with experts, and we're going to theme it COVID-19, the impact on families. And as you've heard me say before, additional supports are available through links and podcasts by Professor Michael West, who will have the graciousness of hearing him talk on one of our conversations that matter. So we're looking at proactive communication next week with patients and families and staff, and the need to work together to adapt in the new demands that this COVID-19 pandemic is facing us with. So I'd just like to finish by thanking our panel of guest speakers. Thank you so much, Coleman. Thank you so much, Nuala. John, thank you so much, and indeed Miriam, you also, and all of the people behind the scenes that are making this work, and most importantly to our listeners. And if anyone has any questions or further suggestions for conversations, please contact RCSI Leadership at rcsi.com. So thank you everyone, good night, and we look forward to seeing you next week. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.